Good evening, everyone, and thank you for attending the webinar. I'll cover within this talk on endometriosis and the menopause. Next slide, please. I'll cover the following topics. I'll give a bit of background of endometriosis, a bit of background of the menopause itself, and sorry, Emma, I can't see the next slide. Yeah, thank you. And I'll talk about endometriosis after the menopause, and then talk about management of menopause with endometriosis. Next slide, please. So if we kind of want to, just before starting to talk about the kind of the practical aspect of it, just to give a bit of a historic perspective to it, the reference to symptoms related to the menopause has been around in various references for a few hundred years. But if we want to go back and look as to when it was first, there was a histological description of endometriosis related tissues were described in the literature. It goes back to this paper by Thomas Cullen from Baltimore in 1920, where he reported histologically confirmed what we would describe as endometriosis. He used the term adenomyomas to describe them, but as you can see here, what he described was islands of uterine mucosa and in different parts of the pelvis. Next slide, please.
Sorry, bear with me. I don't know what's there's a bit of a tech delay.
But if we want to look at kind of the first description, coining the phrase endometriosis, was John Sampson from Albany in 1927, and he used the term endometriosis and referred to retrograde, like the dissemination of endometrial tissue back through the fallopian tube into the pelvis, which we describe as the retrograde menstruation cause for endometriosis, which is the commonest cause for pelvic endometriosis. Next slide, please. So if we want to kind of look at it and say, what are we referring to with endometriosis? So the term itself is from the Greek Latin inside of the uterus, and it basically refers to the tissue, the lining of the uterus, the endometrium, present outside the uterus. And that tissue behaves in a very similar way as the endometrium does. So its response to hormonal stimulation, as hormone levels drop towards the end of the menstrual cycle, that tissue behaves like the endometrium, it bleeds. When that is happening outside the normal environment, which is the endometrium, which is the cavity of the uterus, that tissue can, inside the abdomen, can cause irritation to the surrounding tissues, inflammation and scarring. And that process is the cause for the manifestations that we generally see with endometriosis and the manifestations that we have with it. So it is an estrogen-dependent disease, and as with that goes, it's a disease of the reproductive years. So it can, generally speaking, it's during the reproductive years that women can experience symptoms with it, and it generally regresses after the menopause, and I'll cover that a bit later on. Next slide, please. And if we look at this cartoon, you can see the lining of the uterus, the endometrium, which is where this process, you could say month in, month out, this response to hormonal stimulation, it thickens, it sheds, and a period happens. But when this tissue is present outside the uterus, as you can see in these red dots outside, it's going to behave in a similar way, but outside the normal environment. And that can cause inflammation, scarring, and the symptoms that you see with endometriosis. Next slide, please. So if we look at demographics of it, it commonly affects women in the reproductive age group, so common age 25 to 45. It's estimated that more than 1.5 million women in the UK are affected by it. There's often reported delay in diagnosis. So it's reported that on average about 8 to 10 years between onset of symptoms until diagnosis. And of course, this can be frustrating to many because many people can go on with symptoms for a number of years before something is done, before it's identified. And if we want to look at prevalence, if you look at it generally in the reproductive age group, it's estimated to occur in about 6 to 10% of people. But if you look at specific groups where there is a higher association, the prevalence becomes higher. So if you look at fertility groups, you find it's about 10 to 20%. And if you look at chronic pelvic pain, it's estimated more than 70% of people in that group are noted to have endometriosis. And one of the associations or complications of it is the small risk of malignant transformation, which is estimated to occur in about 1%. And I'll talk about that a bit later on. Next slide, please. So again, if we want to look at it from an association, there appears to be an association between endometriosis and the onset of the menopause and earlier menopause. So from this large cohort that you could see from the Nurses' Health Study, more than 100,000 people assessed, there was a significant association. And what they included in this group were people who had laparoscopically confirmed endometriosis, and they noted a significant increase in the risk of early natural menopause before the age of 45. And this may be related to either endometriosis developing in the ovaries and causing damage to ovarian tissue, potentially surgery to remove this endometriosis. And again, that can affect the ovarian egg count and reserve and increase that risk. But it is noted association. What they noted as well was that people who had children had a lower risk. People who had taken hormonal contraception had a lower risk. So both these two areas were protective in that respect. Next slide, please. So what causes endometriosis? We're saying it's tissue, the lining of the endometrium present outside the uterus. How does that happen? So the commonest theory, at least, that explains pelvic endometriosis, so endometriosis in the lower part of the abdomen, is the one that I referred to, the retrograde menstruation. And within that, what is described is that the lining of the endometrium with the menstrual cycle, some of it goes back through the fallopian tube and implants inside the abdomen. And that is the likely explanation for endometriosis that we see in the pelvis. And of course, you have to think of it and say, that individual is probably predisposed to have endometriosis because retrograde menstruation is very common. And you could say, well, why wouldn't all women have endometriosis when it's that common, or why would more happen? And it's probably some element of predisposition that some people will have it, but that is the theory behind it. But of course, we do see endometriosis in other areas outside the pelvis. And again, this may be explained by going through the blood vessels or the lymphatics, or changes in the tissue. So sometimes we see endometriosis in the upper part of the abdomen, under the diaphragm, in the lungs sometimes, and this could maybe explained by these other theories. But again, if you look at the genetic predisposition, and altered immune reaction probably plays a part. As I was referring to, you could say, why would one individual have this and another wouldn't? So that probably will contribute to this, to that developing endometriosis. Next slide, please. And if you want to look at the retrograde menstruation theory, you could see here in the top part of this diagram, you can see the fallopian tube, and you can see the blood and the cells coming through. So they implant into the tissue, let's say in the scenario, the peritoneum, which is the lining of the abdomen. And in the earlier stages, that can appear red because of the blood contained within the tissue. But as time goes by, that blood becomes old in color and becomes black. And as the body almost tries to, as a result of this inflammation trying to contain it, you get scarring and it becomes white. So in the next slide, I'll just show you a diagram. It's a surgical image. So if anyone is a bit squeamish, the next slide does have some images. You could just avoid that. Next slide, please. And you can see here on the top left, the red area, which is sort of the early active stages. And as that blood slowly converts and becomes old blood, you can see in the bottom left, it becomes black. And you can see in the bottom right, it becomes white as the body it causes scarring, inflammation, and you can see it in that area. And same thing on the top right corner. Next slide, please. Now, what areas are affected commonly is the pelvis. So it's the area in front, it's the area behind the uterus, area in front of the uterus, area behind the ovaries, around the ovaries, around the fallopian tubes are the areas that we can commonly see these lesions. And the lesions can vary. So they could be smaller lesions, they could be bigger lesions, they could be superficial lesions, they could be deep infiltrating lesions. And a part of it is, what is the lesion doing? How deep is it? But equally is, how is the body reacting to it? How is that inflammation and scarring affecting the organs around it? And that can play a significant part in how the manifestations that we see in the clinical presentation with endometriosis. And of course, you could have the bladder can be involved, bowel can be involved, and you could have further organs, as we're referring to, the diaphragm, the lungs, and so on. Next slide, please. And again, you could see in these images, so you could go from lesions that are isolated, that are not causing much inflammation and damage beyond where they are, as the top right image, or you could go on to that middle image where you could see a uterus, the bowel is adherent to it, the ovaries are adherent to it. So there's significant inflammation that has affected the organs around where the endometriosis is. And of course, this can cause, it goes without saying, when you look at this, you could say this is likely to cause pain, discomfort. It can have other manifestation given the extent of scar tissue involved within that. And the same thing with the bottom right picture, where you could see an endometrioma, a cyst in the ovary, and adhesions between the ovary and the uterus and the area around it. Next, please. And the lesions, again, by definition, when we describe deep infiltrating, is generally more than 5 millimeters in depth. And of course, again, depending on where they are, they can cause symptoms within these organs. So you can see at the top right, there's an image of an endometriotic lesion in the bladder. At the bottom right, you can see here a lesion, probably the picture is not very clear, but occluding the ureter, which strays between the kidney and the bladder. And as a result, the ureter is dilated and the kidney on that side is dilated. So this is, again, beyond the symptoms. This is having other potential health effects as a result. Next slide, please. So how do people present who have endometriosis? So the presentation can vary, and as a result, the treatment would vary with that as well. So you can say that pain is the common symptom that people present with, and that could be pain, generally speaking, before the menstrual period, or during the menstrual period, or pain with intercourse, or it can be infertility as a result of the inflammation and the scarring that forms with endometriosis. It could be both pain and infertility, but also it may be asymptomatic. You may be doing a laparoscopy or an operation for something else, and you find a few spots of endometriosis or more, and the individual was not aware of them. So that's why treatment is really important to be directed. It's relevant to say that it should be directed to what the symptoms are. So if someone has got pain as the main issue, you would say treatment could be medical or surgical. Medical treatments largely work through suppression of ovulation. So as generally speaking, it's going to be hormonal treatment that suppresses ovulation. But of course, it can be surgery where the lesions are either treated with energy or excised. And again, infertility, which may be caused by inflammation and scarring, again, could be either treated through IVF and active fertility treatment or surgery. But again, if it's identified and it's not causing symptoms, then one would say, do you need to do anything about it? So it all depends on the extent and the presentation and how it's affecting the individual. Next slide, please. So in the next part, if we want to just talk a little bit about the menopause itself, what happens there. So again, the term menopause is again Greek, Latin, and marks the cessation of the menstrual cycles, and it marks the end of the reproductive life cycle. Next slide, please. So if we want to look at the demographics of the menopause, so the average age of onset of the menopause is 51, but it's a range. So you could say the normal range is 45 to 55. Some people go late into the menopause. It's estimated 20% of people can go into the menopause at 54 or beyond, but some can go early. So 5% of people can go into the menopause between 40 and 45, which we describe as early menopause. 1% can have premature ovarian insufficiency or premature menopause, and that's under the age of 40. And you could say in the context of endometriosis, that's relevant, because you could say individuals who have surgery, who end up having a surgical menopause, will fall into that category. And again, when you're in that group, you're going to look at a number of aspects. You're going to say, what symptoms can the individual experience or may experience? What can you do about them? What health implications would it have from a bone, from a cardiovascular, from cognitive health? So there are many aspects that come with it. But when we talk about symptoms, so menopausal symptoms are very common. So it's estimated about 75% plus of individuals will experience symptoms during the menopause. Not all will. So about 25% will go through the menopause with minimal symptoms. So it's a really varied presentation. And also the duration of symptoms varies. So if you look at it, you could say that average duration of symptoms is about 7 years, but 1/3 of individuals can have long-term symptoms beyond that. What are the symptoms? Well, if you look at the common symptom of hot flushes and night sweats, described as vasomotor symptoms, you could say an individual can self-diagnose these symptoms if they have them. They can self-diagnose the menopause if they have these symptoms. But not all individuals we see have hot flushes and night sweats, and not all will have these as a predominant symptom. So you could see people who describe disturbed sleep, insomnia, poor memory and concentration, brain fog. And we see many individuals who will say, I'm really worried I might be having dementia. Why can't I don't remember names, I've sat something and it just goes. And it's not imagining it, it is an estrogen deficiency symptom, and it's not dementia, so it's not an impairment in cognitive function, it's an estrogen deficiency symptom that responds really well and quickly to estrogen replacement. And it's very different to dementia or dementia prevention. So you can look at it and say every woman at some stage is likely to go through the menopause. Very small proportion will experience cognitive impairment longer term, and that kind of puts it all in context. But you can get mood changes, you can get anxiety, joint aches, fatigue. Often fatigue is a multifactorial, so it's a difficult really one to kind of pinpoint, but can be associated with these. Low sexual drive, many individuals wouldn't feel comfortable talking about it, but can have a significant impact on where they are. And when in the context of endometriosis, you've got the compound aspect of the dyspareunia and the pain with intercourse that comes with it as well. Urogenital symptoms, genitourinary symptoms, again related to estrogen deficiency, are very common. So these are all symptoms that people can experience. But as I said, symptoms are one aspect. You have to think about, especially when you're talking about an early onset, about the impact on health. So if you have someone who goes into the menopause before the age of 45, symptoms is one aspect, but you also have a discussion about health implications, bone, risk of osteoporosis, risk of cardiovascular disease, potential risk of cognitive effect with estrogen deficiency are there. And of course, also in the younger age group, fertility can be an issue, and it's important to counsel about it pre-surgery if someone is about to have surgery, but also to talk about it if someone has had a natural menopause, because to many that may be an issue that they would want to address. Next slide, please. So what are we giving with HRT? What are you actually prescribing? Well, estrogen is the mainstay of treatment, and estrogen is what you're giving for symptoms. You can give testosterone, particularly if there's low libido, can complement that. And progestogens you are giving for endometrial protection. So generally, out with endometriosis, if someone has had a hysterectomy, you would say you give estrogen, you don't need to give progestogen. But of course, that might be different with endometriosis, and I'll talk about that. So with estrogen, you could give estradiol, which is a body identical, similar biochemical structure to what the human ovary produces, which can be in an oral preparation or through described as transdermal, which may be gel, patch, or spray preparations. You've got conjugated equine estrogens, which we don't really use that often these days, and they're not as good as estradiol. Progestogens, you've got micronized progesterone, which is again the body identical, similar to the chemical structure of the progesterone produced from the human ovary, but we've got the synthetic progestogens, again different preparations. And testosterone gel preparations often use off license, because we haven't got a preparation license for female use, but we've got gel preparations that can be used for this context. Next slide, please. And this is just to kind of demonstrate, generally speaking, of what are we giving, how we give it. So you're giving estrogen within HRT throughout the cycle. So this is different to how you give the contraceptive pill, where you give it for 3 weeks and you have a week's break. So you're giving it all throughout the cycle. If an individual has had a hysterectomy, then you only give estrogen only. And as I said, this is really out with endometriosis, generally speaking. If someone is perimenopausal and they're still having menstrual cycles, we give the progestogen in a cyclical way. And that's the second part of the diagram. And the lowest part of the diagram is when you give continuous combined in someone who's menopausal, who has stopped their periods. So if we move on to the next part and say, right, what happens with endometriosis after the menopause? So as we were saying, it's an estrogen-dependent condition. And of course, estrogen levels are generally high in the reproductive span. And as an individual goes into menopause, estrogen levels become less. So generally speaking, endometriosis becomes less active and regresses with the onset of the menopause. But it can continue to grow, and the data do suggest that endometriosis can be present after the menopause. And if you look at prevalence data, this is German registry data, estimated to be about 2 to 4% of postmenopausal individuals are estimated to have endometriosis. So then if you ask the question, what is that endometriosis? How do these lesions develop? So there is a possibility that you have got an active lesion that continues to be active. There is a possibility that you've got a lesion of endometriosis that becomes reactivated as a result of exposure to hormones, and these could be externals. For example, someone's taking HRT, or breast cancer patients taking tamoxifen, which can be a potential risk factor. Could be internal exposure to hormones. So the body converts testosterone to estrogen. So you could say with obesity, that would be a risk, a potential effect. Or it could be activation of estrogen within the tissue itself that triggers it as well. And again, there is a theory as well. There's some suggestion that there might be new lesions developing. So these are not necessarily pre-existing endometriotic lesions, but we really don't understand that process fully. And again, there's little literature on postmenopausal endometriosis. Next slide, please. So again, if you want to look at it and say, what did the published studies tell us? So what happens if you take HRT and you've got a history of endometriosis? What information have we got on that? Again, if you look at the systematic review, the answer is we know very little. So if you look at it, there were 17 patients in total in reported studies who had recurrence of endometriosis on HRT. So limited information. And I think when we start talking about malignant transformation and reactivation, it's important to keep in mind that a big part of this discussion is plausibility and what we're saying, what is likely to happen, rather than saying what we know does happen. So it's taking it all in context. But what you could take from these figures is that the overarching thing that you see with these reports is that the majority of cases are people who have had a hysterectomy and ended up taking estrogen-only HRT with it. So that is the commonest association that you find in all these reports. And also, the other thing that you take from it is that it happens a good few years after HRT is started. So you look here, its average is over 7 years. And as if you say, how do people present? Pain is the commonest presenting symptom in this situation. Next slide, please. So if you look at it again, so this was the first one was reports, isolated reports. This is looking at saying, right, what did the studies tell us? The controlled studies where you individual with endometriosis and you give them HRT and you say, how do they respond compared to the other group who don't take HRT? So controlled studies. And again, if you look here, very little evidence. So this Cochrane review included 2 small studies and concluded that if you had endometriosis and you took HRT, you probably had an increased risk of reactivation of the endometriosis, but the numbers were small, really, to draw meaningful conclusions. Next slide, please. So if we then look at the risk of malignant change or malignant transformation of endometriosis. And again, I would start by highlighting the 2 points of one of them saying this is rare. So we're talking about a 1% risk. So it's a small risk, and that shouldn't be a cause for, in a way, anxiety about it, but it's important people are aware of that small risk and try and understand where it fits in the discussion about what you do. But also the other point is to say is the evidence is limited and we've got uncertainties with it. So if you look at this review, so a total of 90 cases. So the numbers are small, and this is from 75 different studies, so mainly case reports. What can you take from this? Well, you can look at it and say 65% of the patients who are identified to have malignant transformation knew that they had endometriosis before. So the reverse side of that figure, 1 in 3 individuals did not know they had endometriosis. So they would have had a mass, it got investigated, it got treated, and found to be a malignant transformation, which is so quite a significant portion wouldn't know that they've got endometriosis. 2/3 had a hysterectomy, and of those who took HRT, the majority, as I was saying earlier on, took estrogen-only HRT. So again, that's the theme that you see recurring with reactivation, be it with malignant transformation. And also another interesting figure is this figure about tamoxifen, the patients with breast cancer. So we often counsel patients with breast cancer who take tamoxifen that there is a small increased risk of endometrial hyperplasia and cancer, but this is not often talked about, that of course tamoxifen can do the same thing to endometriosis. So there is a slightly increased risk that individuals should be aware of. Next slide, please. From a histology point of view, endometrioid adenocarcinoma is the commonest histology. But if you want to ask the question and say, right, how would an individual present? What is the clinical picture? So pain was pelvic pain, abdominal pain was the commonest symptom. So more than half of the individuals had pain. Pelvic mass in 1 in 3. Abnormal bleeding, about 40%. Now, most of these reports are old reports. So at times where you could say it was common to give estrogen on its own after a hysterectomy, higher doses of estrogen were used, different types of estrogen were used. So you could see the survival rates in that group was about 80%. But if you look at the mortality data, there were, so with improvements of treatment, of course, with these cancers as well, there've been no deaths reported from it since 2010. So that's kind of giving a reflection of the background to it. Next slide, please. So this review, again, from looking at the people who took HRT after a hysterectomy, the majority were on estrogen on its own. And again, a longer duration of treatment. That's the thing that you see. So you find that here that this was on more than 5 years with an average of 11 years of intake. Another interesting finding was that the last point there, in saying as time went by over the last 52 years, the association became less. And that, in other words, as time went by, there was less malignant transformation in individuals who took HRT after endometriosis. And that's probably because it's now common practice to say, if you've had a hysterectomy, you've had endometriosis, that you take estrogen and progestogen. We're using lower doses of estrogen. We're using better preparations of estrogen. And that probably is all coming into that explanation. Next slide, please. This is another review, again, really very similar findings, so 62 cases. But again, I mean, the main point to take from this, again, you can see half of the individuals in this report took HRT. So in other words, the other half of the cases who had malignant transformation had not been on HRT. So HRT is a risk, but it's not there in the majority of cases, so to speak. Average duration of HRT intake was 10 years, and again, endometrioid adenocarcinoma was the commonest histology. Next slide, please. So what are the clinical guidelines on this? So this is the guidelines from the European Society of Human Reproduction and Embryology. So they produced an updated version of their guidance in 2022. And what they included here was that it's safe to give HRT after endometriosis. But what they recommended if an individual has a hysterectomy to avoid prescribing estrogen-only HRT and to give combined HRT on the basis that giving estrogen only is associated with a higher, maybe associated with a higher risk of malignant transformation. Next slide, please. And also, the other point that they raised is to be aware of it. So if an individual has a history of endometriosis or without a history of endometriosis has pain symptoms that are ongoing, to keep that in mind, to say, do we need to investigate it? Do we need to do anything about it? If it's ongoing, is there a need to do a surgical assessment? So being aware that this is a disease that can manifest after the menopause. It's not just during the reproductive years. And I think the second point is really relevant in that they said that we need to, when we discuss with individuals, is to highlight the uncertainty of the evidence. So it's to be aware of that risk, how much that risk is, to what extent, and with different preparations. The answer is that we know very little about it, and it does still, there is a theoretical component that comes with it. And if a pelvic mass is identified, that they recommended that this should be investigated, assessed, and treated according to national oncology guidelines within that country, because of course these were European guidelines. Next slide, please. So what would we like to see in future areas? Well, we would want to know a bit more in controlled studies, what are these risks? So when we're saying, take HRT, taking progesterone or progesterone with HRT minimizes the risk, then what we don't know is what's the difference between cyclical HRT and continuous combined HRT. Of course, continuous combined, as the same logic with the contraceptive pill in the reproductive years, is likely to be associated with a lower risk of reactivation, and that would be, of course, would be suitable for individuals who've gone through the menopause. But of course, the hormone-containing intrauterine systems provide a similar effect. So if you're taking HRT and you've got a history of endometriosis, it would be worth considering this and saying, right, if you're going to take a combined preparation, it's less risk of reactivation of the endometriosis compared to a cyclical preparation. And also we need to have, ideally, national and international registries to log these cases. So then you can know what is the prevalence of endometriosis after the menopause, what's the risk of reactivation and recurrence of endometriosis, what's the risk of malignant transformation, to get more information on it. Next slide, please. So in summary, endometriosis can occur and recur after the menopause. And it is important to counsel individuals about the limitations and the uncertainty of the evidence. We were mentioning about giving HRT, combined HRT, after a hysterectomy. What do you do if someone has got a spot or two of endometriosis and has a hysterectomy for something else? It becomes a gray area, because you could look at it and say, in that situation, what you're doing, you're balancing the risk of reactivation and the very small theoretical risk of malignant transformation versus the known increased risk with combined HRT from a breast cancer point of view. So there are areas that it's important to take that into consideration, and also how the individual feels about them, and how certain we are in this conclusion. And of course, is to say that if you've had a hysterectomy and you've got a history of endometriosis, is to consider combined HRT, either HRT or Tubolone, which has estrogenic properties, progesterogenic properties, and androgenic properties to minimize that risk of reactivation and malignant transformation. Next slide, please. And also to sort of say, to keep the diagnosis in mind, to be aware of it, to investigate and assess if the symptoms are ongoing. And of course, there may be a need for surgical assessment and to confirm the diagnosis, obtain a histology, and of course, if there is any suspicion of malignant changes, to assess that. Next slide, please. Thank you. And I've put here some links for further information. So this is a link to the ESHRE guidance, and you've probably seen the link to Endometriosis UK. But also we've got a video of endometriosis and menopause on the British Menopause Society website, and I've put the link to that if anyone would like to have a look at that. And I'll stop here and be happy to take any questions with Nitish.
All right, question time. Thank you so much for the informative talk. I can tell we've got a lot of questions in, so I'm going to start with the ones that have been pre-sent and alternate. So my first question is, if taking the combined pill continuously to stop periods, how do you know when you've reached menopause?
So if you are on the pill continuously, of course, diagnosis of the menopause is combining a cycle pattern to symptoms to timing. So of course, you wouldn't really know theoretically until you stop the pill to see what's going on. So comes the question of where is the individual from a pain point of view? Where are their symptoms? So let's say you're in your 40s, you've got no contraindication to coming off the pill, you're happy with the pills, giving good symptom control. General guidance is to say you continue with it till 50. But of course, if someone has got reasons to stop earlier, maybe weight issues, maybe vascular risk factors, that might need to happen earlier. So you really would say at some stage from a safety of the pill comes the question of how long should you continue with it? And that'll really be the drive in this discussion, because once you approach the age of the natural menopause, you could say the diagnosis itself becomes less essential. So it's all going to link in with symptom control, and then it's going to be coming off the pill at some stage to see where that individual is.
Okay, and Nitish, do you have anything to add?
No,
no, I just thought.
No. I think Haitham has covered it. Yeah.
Okay, fantastic. So someone's put, are there particular HRT treatments better suited to people who are in and who have endometriosis and perimenopausal?
So, I mean, the concept as a group, you would say the continuous combined is what you want to give. And again, this goes back to what I was referring to, that saying, like, if you follow the same logic with the contraceptive pill in the reproductive years, that you if you're trying to keep the tissue inactive, you want to give the progestogen continuously. And that's what you do with continuous combined. Now, you can't choose to do that if someone is perimenopausal, because if you're going to give them continuous combined, they're going to have erratic bleeding through it. So let's say you're 48, you've got irregular periods, and you've got endometriosis, and you've got symptoms, and you're going to HRT, and you say, right, can I take continuous combined? It's not ideal because you're going to bleed through it. So in that scenario, you might choose an option to have a Mirena, like a hormonal intrauterine system. You could choose an option of taking HRT with desogestrel. So really having an element of continuous progestogen in the background to keep the endometriosis tissue inactive. So going back to that point, in that group, I would say the Mirena would be ideal because we know it works really well for controlling a pelvic endometriosis, so continuous combined. Or if someone is menopausal, of course, continuous combined HRT would be an option either by tablet or by patch.
Thank you. And my next question is, I thought, well, someone's asked if retrograde menstruation was considered an old theory.
It's really a combination. It's almost saying it's looking at it and saying it describes certain types of endometriosis that you see. So of course you could look at certain aspects, certain areas where you get endometriosis where that theory wouldn't explain it. And so there have been criticisms about that theory and how applicable it is in that respect. And again, it goes back to the point, you could say, the counter argument that I referred to in saying retrograde menstruation is very common, but only a small proportion of people get endometriosis. So it's that predisposition to it. So I think, I mean, the more you look at it, the more you will say your predisposition plays a big part to it. And probably that theory, in my view, would explain the majority of pelvic endometriosis cases. But of course, when you look at endometriosis further up in the abdomen or elsewhere, lung, etc., of course, the other theories will come into explanation. Nitish, if you want to add anything to that.
No, I agree with you. I mean, it is a theory which has stood the test of time. It's just either the volume of the retrograde endometrium is too much, and that is evident in women who have heavy menstrual bleeding, who have or sequestered bleeding, who have a higher incidence of endometriosis, or in women who have got a predisposition in certain tissue areas. Most common is in the posterior pelvis, because that's where we find endometriosis. And again, a good supporting argument for transplantation of retrograde menstruation endometriosis, because most endometriotic lesions are found in the posterior pelvis, where it is where it gravitates to. So there is a lot going for the retrograde endometrium, which is flushed during menstrual cycle, as a causative element. But there are other interactive elements like predisposition, maybe the type of endometrium which is being regurgitated through the fallopian tube is different in some women as opposed to others as well. So there might be an element of invasiveness and attachment which is not there for for other endometrium. So variety of factors play a role.
Sorry, didn't realize I was on mute. So what is malignant transformation, and how do we ensure that it won't become malignant?
So malignant transformation is almost like it's a cancerous change in the endometriosis tissue, and you could say, along the lines, you could say, of what happens within the endometrium itself. So as the tissue becomes abnormal, the division of the cells, as happens with cancer cells, progresses to an abnormal way. So it is a risk, but I think the point that one would highlight is to say, take it in context. The risk is small. It's important that people are aware of it, but also not to worry about it, because you can look at it in a different way and say, many individuals with endometriosis will have pain, and you don't want to be thinking each time you've got pain, what's going on? Have I got something that I need to worry about? It's a question of, are there persistent symptoms? Has there been a recent change? Is there a mass? Is there anything worrying? And you could look at it in a different way and say, we do that anyway. I mean, if someone has a mass, you will go and investigate it, and you'll do imaging, and it's done very quickly to say, is there anything that we need to do about it? So I think the main thing to take about it is to say, the main message to take from it is to say, it's a small risk, be aware of it. And if you've got symptoms that you feel have changed significantly over a period of time, to seek advice to say, what do I need to do about it? Nitish, do you want to add anything to that?
No, thanks, Haitham. Yes, I mean, it is, the problem is, unlike endometrium, which is normally situated in the womb lining, which presents by means and declares itself by bleeding, which is usually postmenopausal or perimenopausal bleeding. The endometrium, which is ectopic in this case, outside the uterus, which is essentially what endometriosis is, can also undergo significant risk of malignant change, and that probably is age-related, although we don't have a good understanding of the natural history of the disease. So it does become difficult diagnosis. And unlike Haitham has said, if you have symptoms and if imaging findings show pelvic masses, or if they show even ovarian cysts as you approach menopause or beyond, then they need to be investigated. In my 15 years as a consultant, I've come across maybe 1 or 2 cases of malignant change in endometriotic lesions. And so it's not very common. I think stating that it is up to 1% is probably an overestimate. Probably it is much lower than that. Whether you have effective treatment of endometriosis at an earlier age, including surgical and medical, whether that would reduce the risk, again, we don't have the data to suggest that. And so, yes, like Haitham says, be aware. And, whether some patient groups should be more aware and, more worried. Difficult to say whether women with history of cancers in their family of certain types should be more aware and worried. Again, difficult to say. It's a disease which we don't have a full understanding of, and primarily because it's more difficult to understand and capture, because it presents like any other endometriotic related symptoms and signs, which is common mode of presentation for most women with endometriosis.
Thank you. And so the NICE guidelines say not to prescribe the combined pill after 50 and due to slightly high risk of breast cancer and blood clots. But does that apply to those with endometriosis?
Yeah, the same thing. I mean, really, you could say not. I mean, really, more is the risk of blood clots than the breast cancer side of things. But yes, so certainly you would say, as age progresses, you would say, do you really need to be on a combined pill? So you kind of need to review the risk, the background risk factors, weight, vascular risk, smoking, etc., and what you're giving it for, and can you alternate with something else? So can you switch to a progestogen only form of hormone? Can you look at a hormonal intrauterine system? All of these will come into it. But generally speaking, you would say, as you approach 50, you would say you want to think from a vascular point of view, is a combined pill the right thing to do? But of course, all these things, you have to individualize it. I mean, you do have people with problematic symptoms. It's balancing what's giving them control, what are the options, and counseling them about the risk. The breast cancer side of things, you could say, it's the progestogens used in the combined pills are the same as with HRT, and the risk is small. It's there. I mean, of course, it's important that people are aware of these numbers, but I would say more of a concern would be the thrombotic effect in that scenario, and probably would want to think about that as you're going beyond 40 and approaching the late 40s. Nitish, is there anything else you want to add to that?
No. I mean, it's not very common to prescribe a pill after the age of 50. So, if anything has to be prescribed at that age, it would be HRT, which would be more lower doses and more natural forms of hormones rather than synthetic versions and higher doses, which are there in the contraceptive type of pills.
Okay, thank you. I know we're running short on time, but just because we started late, is it okay with both of you if we just go 10 minutes over? Is that fine?
Yeah,
thank you.
Okay with me.
Thank you. So can endometriosis and high doses of progestogen cause menopausal symptoms? If yes, what treatment can be given to counteract the menopausal symptoms?
So unlikely. I mean, really, you could say the prevalence of symptoms. Again, I mean, you could say data-wise, we don't know, but it's unlikely from a plausibility point of view that the prevalence of symptoms would be different in someone with endometriosis or not. Progestogens, I mean, really, you could say, if anything, they give you some benefit in symptom control. I mean, they're not used as a treatment for menopausal symptoms, but they do have a beneficial effect. So you're unlikely to have worsening symptoms from that point of view. So if you're on a progestogen treatment for your endometriosis, well, it's not a treatment for menopausal symptoms, but it may help a little bit. Combined hormone conception, again, you could say it's a synthetic estrogen, but it can have a beneficial effect in treating. So it shouldn't be, there wouldn't be an association with either of these, or it wouldn't be a negative association with either of these.
Okay. And will a hysterectomy ease endometriosis symptoms?
Well, suppose you have to look at it and say, what symptom are you referring to? What symptom are you treating? So you've got, I mean, of course, if you're saying someone has got heavy, painful periods, then you could say what you're doing with a hysterectomy, there'll be no more periods. And of course, you have to look at it and say endometriosis, by definition, is endometrium outside the uterus. So that is the kind of the starting point. So you could say the symptoms that you're having from that disease, the hysterectomy is not necessarily going to deal with them. Adenomyosis, which is a slight variation, of course, can cause heavy painful periods, and that you would say a hysterectomy would help. So I mean, generally, people who end up having hysterectomy, it's heavy, painful periods. And often when you're going to do the surgery, you're going to treat other endometriosis. And hence you find people who have the treatment generally will be in a better place. But it's important to say that symptoms that you've got from other causes of the pain or endometriosis outside the uterus, that may not change. So it's all about the counseling. It's all about what symptoms the individual has. Nitish, what are your thoughts on this?
Yeah, I mean, and I saw in the pre-questionnaires, there was a lot of questions about hysterectomy. I mean, as a means of relief of symptoms, we have to see whether the pain is menstrual related or it is at random at other times. If it's menstrual related pain or ovulation related pain, then there are clearly things which may, especially the menstrual ones, may be treated by, hysterectomy very successfully. If it's ovulation related pain, and if the ovaries are left behind, then those symptoms might still occur after a hysterectomy. So it's also understanding what is the part of, or what type of pain and when it is occurring, and what is the material relief that each patient is needing, and tackling it, rather than just saying hysterectomy is a solution for all types of pain.
Okay, thank you. And I've had a couple of people ask about how to get involved in research trials.
Yes.
Again,
yeah, carry on.
Just carry on.
Yeah, so we've got 2 or 3 research trials going on. A couple of them are looking at surgery for deep endometriosis and mild endometriosis. In the past, we have had trials going on for novel medical molecules which might affect endometriosis, and they have been in various phases of development. So there are research trials going on. They are advertised quite widely by the sponsors. Most of them are commercial research trials, or some of them are investigator-led research trials, but of a multi-center nature. And they are quite well advertised by the sponsor. The sponsor is the one, basically the sponsor could be anyone, but it's basically the one who's chief investigator for a local or a national trial, who will want participants in the trial. So there are various forums on which, and including Endometriosis UK, where these trials will be advertised. And the participating centers will be on the trial websites, and you could always approach the centers for participation in the trial. There are 2 aspects of participation in trial. One, you have to understand that you may be given a treatment, including no treatment, what we call placebo, which may not benefit you, or you may be given a treatment which may in hindsight benefit you or even have some side effects. So it is a trial. There is nothing definitive in terms of what the outcomes may be, but there is an altruistic element in it, in that your participation will help maybe yourself in the future, but also other women in the future who may benefit from your participation in the trial. So I would encourage you to look out for trials, see where they are occurring, and participate in them. Or consider participating. I wouldn't say participate.
Thank you. And is there a test for menopause or perimenopause?
So often, I mean, if you want to look at it, you say it's mainly a clinical diagnosis. So, so you look at it and say age, change in menstrual cycle pattern, and symptoms is what we would use to diagnose the menopause, let's say 45 and beyond, so almost the natural age range. With a younger onset of the menopause, we do testing because it's got more of consequences. I was referring to the bone, the cardiovascular, the potential cognitive. So generally speaking, if you've got someone who is suspecting an early menopause or premature ovarian insufficiency, we do follicle stimulating hormone testing to complement the picture. Now, these tests are useful to an extent, but they have significant limitations. So if you have an abnormal high level, you will say that's suggestive that the egg count is low and that individual is at a higher risk of being in this situation. It doesn't mean they're menopausal, because you may have an abnormal blood test and you have periods every month, every 4 weeks, 5 weeks, and you're still having cycles, but your egg count is low. So these tests can be used to guide that wider discussion. Anti-Mullerian hormone is another test that looks at kind of a reflection of egg count. Again, not by a self-diagnostic of the menopause, but can complement the picture. So it would tell you that that individual may have low egg count. Again, where do we use it? Generally in the younger age group. But let's say, and of course, surgical menopause, it's a defined area that the individual will be aware of. But with natural menopause, you would say, you often go with the clinical picture. So if you, let's say you're late 40s, you're beginning to notice changes in your cycles, you're getting the symptoms. But where it becomes a little bit difficult is to say, as all things in medicine, there's a lot of gray, there's very little black and white. Not everyone is going to have spaced out periods and hot flushes, and you say, oh, you're perimenopausal. You find many people, as they're going down that spectrum slowly, their cycles are still relatively regular. You're beginning to get symptoms, you're forgetful, you're a bit low, you're a bit anxious. Is it life stresses? Is it menopause? And that's where it becomes a little bit difficult as you're progressing. And of course, with time, the cycles begin to space out. With time, the symptoms become more prominent. Hot flushes are often become, in a way, noticeable, and that can highlight it. So it's almost saying, being aware of what can happen, but also one would always say, don't always look at it as the menopause equals bad symptoms and a difficult time. 25% of individuals don't have symptoms, 50% have moderate symptoms, 25% have what they would describe as severe symptoms. So each individual may have a different experience with it, which may be a shorter duration, maybe a longer duration of time. So it's all about that individualization.
Thank you. And if you didn't want to take HRT, are there any other options?
Yeah, so again, it's a good question, because as one, you would say that really menopause should not be seen as equals HRT, and HRT should not be seen the answer to all issues with the menopause. I would say look at it as an opportunity to look where you are from a general health point of view, and many lifestyle changes have a significant, are very helpful in managing menopausal symptoms. So changing diet between carb, caffeine, sugar, alcohol, smoking, reducing all of these can help. Exercise is very helpful. Leaving aside the mental side of it, that's going to help you, is to say that it has been shown in many studies that it's really helpful in managing menopausal symptoms. Cognitive behavioral therapy, CBT, again, might work for some. Some people might find it not their kind of thing, but it does. That has also been shown to be effective. There are medical non-hormonal options. They don't work that well. They have lots of side effects. So generally speaking, I would often say, combine everything together. Look at what you're doing diet-wise, look what you're doing exercise, look at the kind of whole wider picture, and look at HRT as an option to complement that.
Thank you. And someone's asked, is there any medical recommendations for improving sleep with endometriosis and menopause?
So, sorry, say that again, Emma.
Are there any medical recommendations for improving sleep with endometriosis and menopause?
So sleep, I mean, again, if you kind of go back to the question of saying, what's the association with sleep and menopause, it's a bit kind of, it overlaps. So there's a suggestion to say it's all largely related to the hot flushes and the night sweats, and the hot flushes and night sweats disturb the sleep. That disturbed sleep results in the tiredness, the kind of that memory, the mood. But there is a school of thought to say that there is a direct effect on sleep itself. And of course, many individuals we see will have either insomnia or disturbed sleep. So it's not all about insomnia, it's about disturbed sleep, lighter sleep, change in dream pattern, all of these variations you can see within that process. Nothing that I'm aware of specifically to menopause with endometriosis, but generally speaking, again, going back to how you deal with it, is that multi approach of looking at it from different ways. So sleep in a way, kind of avoiding screen time before sleeping, having sufficient hours, avoiding in a way drinking before going to bed. But of course, HRT is very effective in managing that, and it would be an option, especially if there are other symptoms associated with it.